Uh, Thank you very much, Kishore, for the kind words. Thank you, Dr. GKN, for giving us this opportunity, and Cipla for providing this platform. And like Kishore said, this is a very important topic because erythropoietin is now used left, right, and center, just like Dolo during the COVID times. Almost every patient who's got a CKD is getting erythropoietin from different areas, and indicated, non-indicated, appropriate dose, inappropriate dose. We have no control of it over time. Things have changed, but I think it is important for us to know why many of these patients are not responding to erythropoietin. I hope I'm audible.
Yes, you're audible.
Okay, fine. Okay. So all of us know that anemia in chronic kidney disease is a multifactorial condition. I'm not going to the detail of all these things, but if you have to know about the response and non-response from erythropoietin, we have to know this. So just look at it, multifactorial. It is, there can be blood loss, inflammation, reduced renal clearance, uremic toxins, and most importantly, decrease erythropoietin production. And this is where we give erythropoietin to the patient, and we hope that his hemoglobin comes up. And in most of them, the hemoglobin does come up. But then there are some conditions where it does not, and let's look at that. As we all know, and as Kishore said, it's very often seen in patients with CKD that they have anemic and their outcomes are really bad. But with the advent of ESAs way back in the 1980s, the whole picture has changed. And in 2020, the USRDS report says that more than 85% of the patients on dialysis are receiving some form of erythropoiesis stimulating agent. Now, erythropoietin per se is a glycoprotein hormone produced by the renal cortical peritubular cells, and the oxygen concentration is the one which directly regulates its production. If the concentration of oxygen is low, the higher the production of erythropoietin, and it increases the oxygen carrying capacity of the blood by increasing the hemoglobin level. Now, erythropoiesis stimulating agents, these are recombinant versions of the erythropoietin that is produced in the body, and these are produced pharmacologically. So basically, these are substitutes of the erythropoietin that is produced in the body. And it is a very difficult problem in clinical practice to detect and treat hyporesponsiveness to erythropoiesis stimulating agent. The very important thing is there is no global standard definition of what this hyporesponsiveness is. And depending on the definition, the prevalence varies. But the thing that all of us know and have experienced is that if the patient is not responding well to erythropoiesis stimulating agent, the prognosis is not good. And as the response is even less, the prognosis is even worse. And often what is done is we increase the dose of erythropoietin, hoping that it will act. Like if the patient's sugar is 200, we give a small dose of insulin. If it is 400, we double it or give a much higher dose depending on the control value. So same thing happens very often in anemia of CKD. If the hemoglobin is not responding to erythropoietin, the knee-jerk reaction is to increase the dose. And sometimes this can be deleterious, can increase the cardiovascular morbidity, mortality, can cause thrombotic events, stroke, and even death in these patients. So we have to see why this is happening and then treat the underlying cause. Now, there are many definitions, but basically, in practical purpose, it is defined as the hemoglobin that is not increasing from baseline after 1 month of appropriate dose. Or you have more than 50% increase in the dose of erythropoietin required to increase, get the hemoglobin to normal level. Or we need more than 300 international units per kg per week of erythropoietin, or more than 1.5 micrograms per kg per week of darbepoetin given in the subcutaneous use. These are the various definitions. There are different organizations, and let's look at these things. The European best practice guidelines, the KDIGO, the KDOCI, all these things give the same thing. All of them come with guidelines, but the underlying thing, which is quoted often and accepted as the KDIGO guidelines, which says that you give it for 1 month not responding, or you have to require more than 50% increase in the dose to get the hemoglobin under control. So basically, what is the gist of it is you give erythropoietin at the appropriate dose, hemoglobin is not increasing, or it initially increased, but it's going down and you are trying to increase the dose of erythropoietin. So that is the problem with hyporesponsiveness. And there are numerous factors which contribute to it. most important is iron deficiency. Now you need a substrate for this thing to work. It is like burning a matchstick without a candle or firewood or a fuel. You burn the matchstick, it will burn and then it will die off. But you need something, a substrate. So iron deficiency is very important. Inflammation, which is very common in CKD. The new kid in town, the hepcidin, which has come into a lot of focus in the recent past. Uremia per se, metabolic mode disease, and other malnutrition, which is not related to iron. We'll look at all these things one at a time. Now, iron deficiency is the most important and most common cause of erythropoietin hyporesponsiveness in these patients. And to look at this, we have to look at the biomarkers, the serum ferritin and transferrin. Basically, ferritin reflects the body's iron stores. But the problem is it is not very accurate because it's an acute phase reactant and it may be very high in an inflammatory state. So then we have the other thing, the transferrin saturation. Transferrin is a plasma protein which carries iron across the bloodstream from point A to point B, and it is an indicator of functional iron availability. So the level falls in iron deficiency, and this is what we have to measure. So let's look at what absolute iron deficiency is based on these two parameters. Now the transferrin saturation is less than 20%. And the ferritin concentration is less than 100 in a non-dialysis patient or in a PD patient, or less than 200 in a hemodialysis patient. It is defined as absolute iron deficiency, and the causes are numerous: poor absorption due to whatever cause, inadequate dietary intake, poor nutritional balance, alcoholism, whatever the causes. If the iron level in the body is low, which is reflected by a low transferrin saturation level and a low ferritin level, then there is absolute iron deficiency, and the treatment is iron supplementation. But there is a condition called functional iron deficiency. Here, the body iron stores may be high, like a ferritin concentration will be high, but the transferrin saturation will be low. Basically, there is enough iron stores, but it is not being utilized. And the most common condition is anemia of chronic kidney disease. Then we have chronic disease, not just kidney disease, any chronic disease, anemia. That can have a functional iron deficiency, inflammation, and hepcidin. We'll look into this in detail a bit. Now, inflammation is another important factor other than the total iron deficiency or absolute iron deficiency. After that, inflammation is an important factor which causes reduced responsiveness of the erythropoiesis stimulating agent. And nearly 1/3 to half the patients on dialysis have elevated levels of inflammatory markers like C-reactive protein or interleukin-6, even in the absence of identifiable inflammation or infection. So the patient may be otherwise asymptomatic, but if we check their values of the markers like CRP or IL-6, it will be found to be elevated. And we know that in uremia per se is an inflammatory state. It may be episodic or it may be continuous. And this inflammation is associated with the increased all-cause mortality and also with hyporesponsiveness to erythropoiesis stimulating agent. And why does this inflammation occur? It is multifactorial. The stress of CKD per se can cause inflammation. Then the comorbidities like any other infection, that is that coronary artery disease, then cerebrovascular disease, increased oxidative stress, infections, obesity, dialysis inadequacy, and this will result in accumulation of the inflammatory cytokines, catheter infection, graft infection. All these things contribute to the inflammation, and this inflammation will reduce the responsiveness of erythropoiesis stimulating agent. Now, why does it happen? Because in inflammation, the inflammatory cytokines like TNF-alpha, interleukin-1 and 6 are increased. They are, because of renal dysfunction, their clearance is also reduced. The antioxidant activity like superoxide dismutase, glutathione peroxidase, all these is reduced. Net result is there is an inflammatory cytokine proliferation, and this directly inhibits erythropoiesis and kills the precursors also. There is an increased apoptosis of the erythroid precursors. All this contribute to anemia in CKD due to inflammation. The new thing that is not new, but the thing that has gained recent importance and in the limelight is hepcidin. Now, hepcidin is a liver-derived peptide hormone, and it is one of the key regulators of iron homeostasis. And unbalanced production of this hepcidin can cause to iron disorders. it blocks the iron flow into the plasma. It does nothing with absorption. The iron is absorbed, but then it does not, it prevents the release of iron. And let's look at it. Normally, when the iron levels are abundant, more hepcidin is produced, so it prevents the release of iron into the systemic circulation. And in iron deficiency, the hepatocytes produce less hepcidin, so more iron is released from the storage system into the bloodstream, where it can be used for hemoglobin production. Now, in CKD, there are mechanisms which contribute to the increased level of hepcidin. One is it's an inflammatory status, and in inflammation, hepcidin is high, and also the hepcidin is not cleared by the kidney because of the renal dysfunction. As a result, the hepcidin level increases, and when hepcidin level increases, it prevents the iron from coming out of the various storage areas. Let's look into it. It prevents the iron availability for erythropoiesis, and what happens is this hepcidin binds to ferroportin. Now, iron is taken into the cell through a channel, but it has to come out through the channel called ferroportin, whether it's in the duodenum or from the splenic or hepatic macrophages or from the hepatocytes, reticuloendothelial cells. All these, which are iron storing areas, for the iron to come out, you need ferroportin channel. And hepcidin binds to this, blocks it, and prevents the iron from coming out. So iron is put in a jail within these cells, within the duodenal enterocyte, within the splenic or hepatic macrophages, and within the hepatocytes. Iron is locked there, it is unable to come out. So there is iron overload, or normal iron level or overload, but it is not being utilized, and hence the patient has anemia. And this is one reason, however much erythropoietin you give, it is not going to work, because the iron in the body is not available for utilization. And this is what happens normally. The iron is taken up by the cells and it is stored as ferritin. And when required, the iron comes out through the ferroportin channel. Now, when there is high level of hepcidin, the iron uptake is there as usual, but the channel ferroportin is blocked, and there is iron stored as ferritin within the reticuloendothelial cells, the duodenal cells, as well as the hepatic cells, and the iron is not available for utilization. So, hepcidin plays a very important role in anemia of inflammation and erythropoietin hyporesponsiveness or even unresponsiveness. Then another factor is the metabolic bone disease associated with CKD. The high PTH level directly inhibits the progenitors and reduces the RBC survival, as well as reduces the erythropoiesis. Then bone marrow fibrosis can occur as a secondary complication of hyperparathyroidism, and all this is also associated with erythropoiesis hyporesponsiveness. Then malnutrition of other vital elements, not just iron, but the other vitamins and cofactors which are required for iron, hemoglobin formation and maturation of the RBCs, like folic acid, vitamin C, copper, alpha lipoic acid, carnitine, then vitamin B12, B6, all these things are required for iron, hemoglobin formation and the RBC maturation, and deficiency of this due to various causes in CKD can contribute to anemia. The other factors are drugs like ACE inhibitors and ARBs, which almost all of our patients with CKD get as a factor used to reduce the progression of CKD, and it inhibits angiotensin 2 inhibition. Is also contributing to reduce erythropoietin release. Then malignancy like myeloma, lymphomas, leukemias, primary bone marrow disorders like myelofibrosis, drugs which suppress the bone marrow, aluminum overload, which fortunately we don't see nowadays, but still it can occur, and very importantly, anti-erythropoietin antibody. All these also contribute to hyporesponsiveness of the erythropoiesis stimulating agent. Now, couple of words on pure red cell aplasia. It is a rare condition, but it is serious and life-threatening. Many factors occur, cause this pure red cell aplasia to occur, but in our condition, in our situation, an important factor is the antibody which is produced against the recombinant human erythropoietin. And usually what happens is, there's a patient who's having a normal good response to erythropoietin. Suddenly his hemoglobin starts falling, And despite appropriate therapy or even after increasing the erythropoietin dose, there is no other there is no improvement. And when you do a bone marrow study, there is absolute loss of erythroid progenitor cells, while the otherwise the bone marrow is normal. The white cells, the platelets and all are okay, but there is absolutely no progenitor erythroid cells. And antibodies can be detected by tests in the presence in the serum. And the thing is, it not only acts against the pharmacological erythropoietin, or it acts against the endogenous, whatever little bit of erythropoietin the body produces, this antibody acts against them also. So this is a very dangerous condition, and it was described many years ago, first described in IPREX, when the patient suddenly his hemoglobin started dropping, but it's been described in other conditions like with erythropoietin beta, erythropoietin omega, and even darbepoietin has been shown to produce antibodies which cause prior red cell aplasia. It is not self-limiting. Very rarely it is self-limiting. You have to intervene it. And the most important thing is to stop the administration of this erythropoiesis-stimulating agent, whether it's erythropoietin alpha, beta, omega, or darbe. It has to be stopped. You have to give blood transfusion because the patient will have severe anemia. HP can drop even up to 2, 3, and all those levels. And it has been shown that transplantation has shown to reduce the antibodies because of the immunosuppressants that are being used there. So these antibodies or the cytotoxic T lymphocytes attack the erythroid precursors, and so they are treated with immunosuppressive agents like steroids, cyclosporin A, cyclophosphamide, rituximab, and IVIG. And most of the reports have shown good response with either cyclosporin or prednisolone. And this is what has been shown in the post-transplant situation also. So if the patient develops antibody-mediated pure cell aplasia, stop the erythropoietin, give blood to correct the hemoglobin, and then steroids or cyclosporin, titrate the dose, and you can get a reasonable good response. So coming back, we've looked at the causes of erythropoietin hyporesponsiveness and anemia in CKD patients. Now, what do we do about it? If there is anemia, you have to correct it. If there is absolute iron deficiency, iron supplementation. If it is due to inflammation, correct the inflammation. You have the new drugs like the HIF stabilizers. Then you have treat the inflammatory factors, appropriate dialysis. Very often the patients are dialyzed inadequately, and in such a situation, unless you dialyze them properly, they are not going to get response to the erythropoietin. You might just end up hiking up the dose and patient paying more money. So appropriate dialysis, monitoring the renal parameters or the urea reduction, all those things are important. Correct the metabolic bone disease and look at the factors like non-iron deficiency, the nutrient factors, and correct them if such a deficiency is there. Now, there is no absolute guideline for optimal iron supplementation, but the KDIGO guideline, more than 10 years old, suggests that you give iron if the transferrin saturation is less than 30 or the ferritin is less than 500. If it is absolute iron deficiency, either oral or IV iron can be used. But if it's functional iron deficiency, you have to give IV iron because of the poor intestinal uptake. And if their hepcidin level is high, even though the iron is absorbed, it is there in the duodenal site, cannot come out. So the utilization is poor. So in such case, IV iron is better if there is functional iron deficiency. Now, the new molecules that have come are the HIF stabilizers, and it is very important in regulating the iron homeostasis. It increases the transferrin and the receptor concentration. It increases the duodenal cytochromes and the transporters, increases ceruloplasmin. It suppresses hepcidin and other pro-inflammatory cytokine production. So all these things put together, the HIF stabilizers have an important role in correcting the anemia if the patient has anemia of inflammation. Then if there is other inflammation, there is an infection, treat with antibiotics, correct the infection. No point hiking up the erythropoietin dose or giving more iron when the active inflammation is going there, active infection is going there, it has to be corrected. Now, if it's a chronic inflammatory stages like lupus or whatever, you have to give steroids and control that inflammation. Otherwise, again, your hemoglobin is not going to come up. Then appropriate iron supplementation and adequate dialysis. Very important is adequate dialysis. Many of the patients who go to these peripheral centers are inadequately dialyzed, and they are present to us with anemia when they come with a complication. Now there are drugs which are directly inhibit the hepcidin production, like the monoclonal antibodies have been used, but again, not very commonly used, not easily available. It's though it is theoretically available, not very frequently used. Atorvastatin and is also shown to reduce the hepcidin level. So most of our patients have hyperlipidemia, and many of them are on atorvastatin, so it can be used. Even pentoxifylline has an anti-inflammatory effect and shows to improve the erythropoiesis responsiveness better. So these are the other factors that are used to treat the inflammatory conditions. And there is can't say enough about adequate dialysis. If the patient is under-dialyzed, how much of iron or how much of erythropoietin you give, it's not going to work. So you have to increase the dialysis. The dialysate flow, the blood flow should be high. Dialysate flow should be appropriate. The duration of dialysis should be there. And ideally, the patient should be on thrice weekly dialysis. And if possible, convective dialysis also is better because it will remove the middle molecules. Now, there are vitamin E bonded membranes which can be used for dialysis, but not very often used because the antioxidant effect of vitamin D is supposed to have a better function, but again, not practically possible in all our conditions. So when we use our low flux dialysis, ideally the patient should be on thrice a week dialysis with a very good fistula, having a blood flow of 300 or more, and appropriate corresponding dialysate flow. This will give good dialysis, and the patient's erythropoietin requirement will also be less. Then about metabolic bone disease, secondary hyperparathyroidism, as I mentioned, can contribute to hyporesponsiveness. The hyperphosphatemia has to be corrected. Vitamin D has to be administered depending on the levels, either daily or weekly or monthly supplements, and can be used directly, or the vitamin D analogs can be used. Whatever it is, the metabolic bone disease has to be corrected. Otherwise, the patient is not going to respond to erythropoietin. Then non-iron malnutrition management, you correct the other nutrient deficiency, see what are deficient, but there is no indication to supplement all these if there is no deficiency, because there is a concern of overload and the risk-benefit balance can be altered. So if the patient has deficiency in B6 or B12, yes, we are justified in supplying it. Otherwise, we should not, because we may overtreat the patient also. And this is just a table summarizing all these things which I have mentioned. Basically, iron deficiency, if it's absolute or functional, correct it. Correct the inflammation, adequate dialysis, metabolic bone disease to be taken care of, non-iron malnutrition like vitamin C, folic acid, L-carnitine, etc. to be addressed, and the factors which I had mentioned. If there is malignancy of primary bone marrow disorders, treat the underlying condition. If not, there is myelodysplasia or myelofibrosis, there's nothing much we can do about it, and look for pure red cell aplasia if none of these things are available. So basically, we look at the factors, you assess the patient, you investigate, look at the iron studies, look for infection, look for inflammation, look at the renal parameters, and you can't do it alone. You need help. You need your dietitian to look at the nutritional status of the person. You should, the dialysis nurse as well as the dialysis technician should play a very important role, because they have to make sure that the patient is taking the medicines appropriately. We just give a prescription and then we assume that the patient is taking the drug. So we have to cross-check with them to see if they're taking it. And once we identify what the deficiency, if it is iron deficiency, either oral or IV iron, if we identify an infection or inflammation, treat it. If we are under-dialyzing the patient, increase the dialysis delivery, supplement the non-iron nutrition parameters, and then monitor the patient regularly. And now we have the HIF stabilizers, which can be used. And some of them have been recently been approved by FDA for use. And most of us have experience with desidustat also. So that is another option for these patients. Now, before I conclude, just would like to look at the various types of erythropoietin that are available. We have both erythropoietin alpha and beta commercially available, and darbepoetin as well as sera. And erythropoietin should be ideally given 1 to 3 times a week. Darbepoetin maybe once a week or once in 2 weeks, and sera once in 2 weeks or once a month. And with subcutaneous administration of erythropoietin, the peak plasma concentration is reached by around 18 hours. And the bioavailability is only around 20 to 30%. And with up to 4 days, its level is present in the serum. After that, it is not seen. So we have to give erythropoietin more frequently, at least twice a week. And if the level, if it is given IV, you have a higher peak, but it disappears faster also. So although it is given, to get a longer sustained level, a higher dose of erythropoietin has to be given if it is given IV. So most of us opt to give subcutaneous injection. Now, there have been few studies looking at the frequency of erythropoietin administration, whether it can be given once a week, twice a week, or 3 times a week, and whether what happens when you reduce the dose from 3 times a week to once a week. So there are studies which have shown that the erythropoietin efficacy decreases when the dose is reduced from 3 times a week to once a week, when the gap is increased. Then there are other studies have shown that you can give it once a week, but you have to increase the dose. When you're switching it from twice or thrice a week, when you're making it once a week, you have to increase the dose. But the risk of increasing the doses, you are risking the complications like cardiovascular morbidity and mortality. The long-acting drugs like dabipoietin, you ideally should be given once in 2 weeks, and Sera to be given once a month. So once you reduce the frequency, the study was done comparing once a week versus the conventional thrice a week erythropoietin, and they found that the level of hemoglobin reduced significantly when it was given once a week. And to compensate for that, the erythropoietin dose was also significantly increased, which contributed to increased morbidity and mortality. So that is something that we have to look in mind. Well, there are some other studies which have shown that you can give they've even given it at once in 2 weeks erythropoietin, and they've maintained the level of hemoglobin which is appropriate, but these patients had a higher dose of erythropoietin required. And once the erythropoietin was given reduced to, the frequency is increased to 3 times a week, they reach the target hemoglobin much higher, and the hemoglobin actually overshot. So we have to titrate the dose, the appropriate dose, to get the hemoglobin between around 10.5 and 11. The problem with increasing the doses, by giving less frequency, we have to increase the dose. We are at a higher risk of the adverse side effects, especially the cardiovascular and the cerebrovascular effects. So finally, coming down to the first slide, which I had shown, chronic kidney disease, anemia, multifactorial, erythropoietin deficiency is just one of them, and we give erythropoietin, but if it is not responding, we have to look at the other factors like adequate dialysis adequacy, the hemoglobin, the iron levels, whether inflammation is there, whether hepcidin is overacting. And if these things are there, we have to correct it. And most importantly, if none of these things are there, look for anti-erythropoietin antibody, because just increasing the dose of erythropoietin is not going to correct it. We have to look at the other factors also. Thank you very much.